Hello, and welcome to Beyond the Limb, where we explore physical therapy evidence, expertise, and innovation in limb loss and limb difference care. I'm your host, Will Riddick. I'm a physical therapist myself, focusing on patients with limb loss and limb difference. Today, we're looking at inpatient readmission models for prosthetic training. Traditionally, we would say prosthetic training is done in the outpatient setting, but there are established and emerging programs that are bringing the intensive schedule and supervision of the inpatient setting to patients receiving their first prosthetic devices. You may have heard about such programs within the VA system, but they're also showing up in rehabilitation centers, taking Medicare, Medicaid, and even private insurance. To talk about this, I have with me Meredith Mayton. Meredith is an occupational therapist by background and is the inpatient therapy program manager for multi-specialty at Sheltering Arms Institute in Richmond, Virginia. She leads the limb loss therapy program and started a successful inpatient readmission program for patients starting in prosthetic training. Full disclosure, we do work for the same company, but I'm going to try and give a kind of an outsider view on this thing as we talk. So Meredith, welcome. Thanks for being here. But I'm just going to go ahead and dive in. Just right off the bat, can you give me like a quick background on the organization of Sheltering Arms Institute and kind of what your role is with it?
Yeah, thank you for having me. I'm excited to talk about this program. Just a background, like you said, on Sheltering Arms Institute, we are a 114-bed inpatient rehab hospital. A little bit of a disclaimer there, we are building out another unit, so we will soon have 144 beds, which is really exciting. We have 4 dedicated units to different patient populations, stroke, brain injury, spinal cord injury, and of course, multi-specialty, which is the unit that I manage. That unit encompasses limb loss, but also some other diagnoses like cardiac conditions, polytrauma, things like that. And we also have many outpatient clinics in the area as well. My role, like you mentioned, I'm an occupational therapist by background. I was a treating clinician for about 12 years before I got this role as multi-specialty program manager. And my focus is just the programming that we offer, those patient-facing programs, and also managing the various disciplines that we have within the therapy department.
Awesome. Yeah, so we're going to be talking about this whole idea of readmission. Obviously, we have this really cool program that we're going to be kind of unpacking a little bit here. But I want you to kind of like give us this idea of readmission, of how you would describe it. What does that entail? What does that look like? Or how does that differ from like an initial admission?
Yeah, I mean, the readmission program specific for prosthesis training is really just this program that really offers the patient a robust, immersive, supportive environment. And it's important to really like maximize therapy once these patients get their prosthesis. So the inpatient program really allows us to kind of put someone in the deep end of the pool, really just focus on all of those body mechanics, strength and balance that they need to be a successful ambulator. And also we're in a setting where we can really closely monitor for skin breakdown, pain management. We have a lot of ways that we can really support the patient so that they are successful in the program. It is different than traditional models in that, traditionally we will see patients sort of after that initial amputation surgery. They're coming to us for that inpatient stay to really maximize what they can, which usually is like a wheelchair level user at discharge. And then, we sort of hope that at some point we'll see them again. And so this program really tries to identify candidates and put them in the queue for bringing them back in for that program so that we can kind of support them as best we can, like the moment they get their prosthesis.
I'm curious, when you first bring that up with somebody to have them come back in as part of their program, what's kind of like their initial response?
So the team here is really well versed in this program. So usually their primary therapist is bringing that up to them before I even get in front of them. But I explain the program to them sort of as like, hey, once you get your prosthesis, we want to bring you back in. We ideally are bringing these patients in for about a week to a week and a half stay. But we really highlight that we want to teach them how to use their prosthesis in a way that kind of gets them up and going and walking as soon as possible. And as you can imagine, those patients are very excited at the idea of, wow, I can come back here with these people that I already know and have a relationship with in a place that I'm familiar with, and I trust this team. And I think that alone is really comforting to patients, being able to just kind of connect back with their team and go ahead and get going with their prosthesis.
Yeah. In terms of the kind of program structure, if we can kind of break that down a little bit, I know we often think of, we think of inpatient rehab as typically like multidisciplinary, PT, occupational therapy, speech therapy. What kind of services would you typically include as part of a kind of like a prosthetic training readmission?
Yeah, so I think we really have tried to expand past the traditional model, which usually is just physical therapy, right? For these patients coming back into the inpatient setting, we're setting them up with 2 hours of PT and 1 hour of OT each day. We put in referrals automatically on admission for therapeutic recreation services so that they can hopefully start focusing on getting back to some of their leisure skills, go on a community outing while they're with us. We also automatically refer to medical psychology. And of course, they're getting 24/7 nursing care, 24/7 physician oversight. And then while they're with us, we try to connect them with our support group. We re-engage them in some of our limb loss educational classes that we offer. So we really try to make it like a comprehensive program that kind of meets all of their needs at once.
Okay. Do you also bring in like other like community partners, for example, like an orthotist or a prosthetist, for example?
Yeah, absolutely. I think we're fortunate to already have some clinic hours with those P&O organizations locally. So they are on a site various days of the week. But traditionally, someone comes in for this program, we're notifying their prosthetists right away. It's a great opportunity to collaborate with them and make some real-time adjustments or modifications as they arise during that stay. When they're finally getting up on their prosthesis and just increasing their wear time, you can, of course, run into different hurdles or different changes that need to be made. So having that, kind of immediate addressing of those issues is really important.
Yeah. In terms of this program, we kind of talked about the top of this that we were, typically we think of like prosthetic training occurring in the outpatient setting. As the idea for this program came to fruition, what was kind of like the need? Like, how did you identify a need, or was there like a certain gap that you were trying to fill?
Yeah, so I think, like you sort of referenced already, the traditional model is, for us at least, it was we see these patients after that initial amputation. We maximize their independence, but obviously they're sort of having to go home at a wheelchair level, and then they either go home health, they go to outpatient, whatever the next step is for them, and then we sort of hope that at some point they're going to show up to an outpatient clinic or wherever with their prosthesis. And sometimes these patients are showing up to outpatient carrying their prosthesis. So I know that you have a long history of clinical care, as do I, and we've definitely seen those instances. So I think bringing someone into an inpatient program for prosthesis training the focus is how can we teach them all of those good habits. And
No, I think I get what you're going for, is like this idea of like being able to kind of front load so much of the training. That's very much what, at least in my own practice, that I'm so adamant about including, because um, you know, compared to a lot of patient populations, you have such a dense amount of information that we're trying to cover. Proprioception has changed. How to even put on a leg has changed. That changes the way that we approach our ADLs. The whole gamut. So, yeah, I can see that.
yeah, and I mean, if you think about it from an efficiency standpoint, um, an intensive program really allows you to accomplish more things in a shorter amount of time. So when you're teaching them, what hip muscles they need to engage, how do they balance and weight shift on their prosthesis, um, preventing hip flexion contractures, monitoring their residual limb, monitoring for any skin breakdown while they're wearing their prosthesis. If we can put them in an intensive program, then they are going to become an ambulator much quicker than sort of that traditional model of I go to outpatient 2 or 3 times a week. I take my prosthetic leg with me, and I work on it for short periods of time. But when you think about the hours that patients get in this program, I mean, they're getting, you know, like 16 hours a week here in our inpatient readmission program. So it's just so much more intense and supportive, but it also sets these patients up for success to be lifelong ambulators.
Yeah. What would you say is like especially since you see some patients kind of through an initial inpatient admission, what are some kind of like some of the key, like, I don't know, maybe clinical indicators or some of like conditions or comorbidities that you're seeing, or like kind of what identifies like an ideal patient or somebody that you would want to reach out to about this program?
I mean, first and foremost, the obvious is sort of someone, that has that goal of ambulation and is driven to work towards that. Um, when we go the readmission route and we're identifying candidates that were with us on that initial stay, we already have a lot of insight into those things. We have insight into how much they've participated, how they've been receptive to the education that we're giving them. We also have a really good insight into their medical comorbidities and what we're tracking and monitoring from that medical standpoint while they're with us that first stay. So it definitely is easier to identify those candidates when they're with us that first admission. But, sometimes we do get some external referrals for the inpatient program, and we have been successful in working with those patients' sort of primary providers to capture some of that information that we need. But of course, you need the medical complexity piece. For us, the sort of consistent check boxes are nursing and wound care for skin breakdown, skin assessment, the physicians for pain management and the management of those other comorbidities, and then some of the other disciplines that I've mentioned before. Yeah, I mean, of course, the medical piece is important, but you don't need to necessarily have a really robust list of things. I think any condition that requires medication, anything related to diabetes management, blood pressure management, um, you can definitely kind of capture what you need from that medical piece using some of those things as well.
Got it. With your program, have you gotten patients from out of the area? I ask this question because when I think of like other kind of similar models that I've heard about, like for example, like the VA system. They have kind of a destination care. There's specialty centers across country where people would come in and for a period of time have this kind of intensive rehab setting where it is kind of residential in a way. I've heard Mayo Clinic has it. I know there's a few others across the country that do somewhat similar kind of programs. But yeah, have you been able to market that as like almost like a destination care style of treatment?
We have really been heavily focused on that this past year, especially as our readmission program has evolved and grown. We have had a handful of cases this year from outside of the greater Richmond area, so that's wonderful. We're getting, in the conversation in those P&O clinics outside of our area, which is great. So I think that is definitely a continued focus area for us in wanting to be a destination rehab, especially when you think about the full continuum of care. We have our inpatient rehab hospital. We have all these wonderful outpatient clinics. We have this readmission program. We have a support group. We have a community event each year specifically for this patient population. We really try to create this, I've used the word robust a couple of times now, but just a comprehensive, robust program for these patients so that they can come to us knowing that we're going to take care of them every step of the way.
Nice. And you have patients that are coming out of discharge and sort of that discharge planning piece of things. An initial admission, obviously we'd be looking at something that would be more like, okay, maybe they're going to go home with home health or maybe discharging to an outpatient. You're working with a patient with prosthetic training, which is very outpatient specific. And let's just throw out an example of somebody. Let's say somebody comes from a couple hours away, spends a week to 2 weeks in your program, and then discharges. What does that care coordination look like on the back end of that?
So as part of the requirement on the inpatient side, we do have weekly rounds, and that's a great time for us to plan that next step with patients. There's conversations with our care manager, who is the primary point person for setting up that next step for patients. When they discharge from us, it is, sometimes they do need home health initially. Because of wound care or other complexities or barriers, really. But ideally, we want to send these patients directly to outpatient. And if they've been here for the readmission program, then we definitely try to get them right to outpatient and just skip home health, because we know that we can kind of continue that intensity on the outpatient side and really maximize that prosthesis training.
All right. So we've talked kind of about overall the general flow of the program, kind of what services are involved in this care coordination piece. But I want to kind of turn into like what I would say is like probably one of the bigger challenges of honestly running any kind of rehab program is getting funding for it, getting like insurance approval for it. I have colleagues that I've spoken with that would love to kind of do like an inpatient readmission program in a very similar style, but definitely running into that barrier of they've already been here once. Are they going to qualify? All these kinds of things. So how would you say that like you and like your program are navigating sort of these hurdles in terms of insurance approvals, et cetera?
I think that documentation is really important because that is what the insurance company is looking at. And sometimes you just have the therapy documentation to go off of, and other times you are sort of trying to connect some physician documentation or conversation and the therapy notes. So if you think about it from that perspective, from the therapy side of things, you really want to capture the change in functional status now that they have had because they have received their prosthesis. So the patient's goals have changed. Their goals are now ambulating. So the amount of physical assistance that someone is going to need to get up and move with the least restrictive device is now significantly different than modified independent from a wheelchair level. So when we look at the therapy documentation, we try to coach the clinicians in really trying to focus on how much help someone needs now that they are standing and walking and doing things from that level. So that sort of shift in a goal from being a wheelchair user to an ambulator can really highlight the functional change that someone has now experienced, and that serves as the justification for an inpatient admission. In the same realm, you're talking about a medical necessity, and like I mentioned before, if we are familiar with that patient from their initial stay, there's a lot of things that we can kind of capture there. But otherwise, we're really trying to support through documentation by identifying the need for wound care, nursing care, physician oversight, rehab psychology, the multiple disciplines. So we have really used those as strategies for submitting to insurance so that we can get authorization if they're commercial insurance. As we know, Medicare does not require authorization for an inpatient admission, so that's a little bit of an easy route. But of course, we need a mix of payers. So from my perspective and what I've experienced with our program is in the initial pilot program that we did, where we just kind of tried to get like 5 patients in for this program, I was able to track, what was the payer? Was it commercial? Was it Medicare, Medicaid, any other types of payers that we normally see, and work with our finance department and billing to understand, were we reimbursed for these cases? And so that pilot was really helpful in kind of getting that buy-in from all of the stakeholders, because I could show that, we got reimbursed per the expected rate for all these different payers. We didn't get any denials in that pilot. So that was helpful immensely for the success of this program, because then the admissions team was convinced, our admitting physician was convinced. And, these patients have a shorter length of stay relative to the other patients that we're seeing. So we are really able to serve more patients because of that. So it has a lot of benefits. And it is low risk in the sense that we kind of know we're getting reimbursed. So that risk for getting denials or that risk for not getting that authorization is relatively low.
I think that's a real challenge for from the administrative front, is like that potential risk. And that if you haven't done a program like this before, are we going to get reimbursed for this? Is this going to be a colossal waste of resources in terms of financial resources, to say? Obviously, it's a great investment into the patient. I want to kind of go back to this idea of the documentation. So with the documentation, you kind of said it's like a reframing of the goals in terms of that. Would you say that it is almost like defining like their deficits in light of prosthetic use versus prosthetic non-use?
Yeah, I think that's a good way to kind of summarize it. I think just highlighting how much help, the significant amount of help that someone now needs getting up on that prosthesis, and ideally we're doing that evaluation and that documentation very close to when they've received their prosthesis. And that is really important part of the program that I haven't mentioned. We don't want patients to get their prosthesis and have this limbo period where they're either at home, they're trying to use it, or it's just sitting there. That really is time lost. So the minute they get their prosthesis, we really want to see them as soon as possible, so that we can start getting them up standing, trying to do things from that level. And then, you can imagine that they do need a lot more help to do that, because they've not been doing those things up to this point. So from that side of things, it fortunately, like, it hasn't caused a lot of questions from the powers that be in approving these patients to come to us. I think we've really tried to tackle it from every angle we can so that there aren't questions when we are submitting that documentation. So yeah, I mean, I think we've been lucky that it's worked. And being a nonprofit organization, I think that does lend itself to a little bit of flexibility in that pilot, right? It wasn't like I just asked once and they were like, yes. I had to come to them, those stakeholders, and kind of identify what would this program look like? How is it different than kind of the normal patients that we see? But what is our goal, and what's the anticipated outcome for these patients? And because we are so focused on patient care and patient outcomes, that was the way that I could convince them to let me try this.
Yeah, sounds great. Let's say, if obviously there's a lot of moving pieces to this, the coordination between, this whole continuum of care, reaching out to patients, being that connection point. If you were somebody that was interested in starting a program like this, obviously there's a lot of care coordination. I've heard this word used a lot of, this idea of like a program champion almost. Mm-hmm. Somebody's really in charge of that. What would you say that it takes to be able to like coordinate that, or to start that kind of program, or how would you say that somebody could start this process, and maybe if they had a similar setting?
I think the first is just kind of laying out what you think the program should look like. And for us, we identified, unbalancing the amount of PT and OT that you would normally see in an inpatient setting, where typically it's kind of split down the middle in the time. But for this program, because there's so much mobility happening, in addition to, we're very fortunate to have a lot of advanced technology and body weight support capabilities. So really maximizing that physical therapy mindset. And I'm saying that from an OT, being an OT, they're working on a lot of IADLs and getting those patients back to doing things that they have been wanting to do from a self-care and home management perspective. So having that program or protocol per se to kind of flushed out a little bit is helpful. And then I think approaching from a totally holistic perspective, when you think about all of the different players that have to participate in bringing someone in from a community setting, you're talking about your admitting team, liaisons, primary care providers in the community, family members. So my personal experience is I'm the one serving as the coordinator right now. So I am the one that is having that initial touch point with patients. I'm giving them information about the program, my contact information, and then I try to connect with their prosthetist so that their prosthetist can keep me in the loop as to when they're getting their prosthesis. But I'm also expecting the patient to be in communication with me. I think our ideal state really is what I'm saying. Our ideal state would be to have someone that can kind of reach out to these patients sort of in that in-between. You're working with a lot of different people, and I think if you can understand the flow of things, for us, it's like, okay, we need to set them up for an evaluation so we can get the documentation. Next is we have the completed documentation, and I'm working with my liaison partner to submit for insurance. And then we're talking to the patient about when are we going to bring them in? Do we have the authorization? Do we have a bed? Coordinating all of those things. And then it's communicating to the admissions team that someone's ready to come in. And then it's, there's all these different steps. So if you can be well versed in kind of what needs to happen when, it is manageable. For us, the volume is not high in the number of patients that we're serving in this program currently. It's about 20 patients per year right now. Of course, we want to grow that, but for right now, it is manageable for one person to do as long as you have sort of those go-to partners for that whole, kind of admission process that you can work with.
Yeah, I think you really pull out a lot of values of like building an effective team and being able to like develop that collaborative process
Yes.
to kind of help it roll. Well, kind of one more thing is like, as like you're looking ahead, you've already talked about how you did this kind of pilot, these trials of things to see, are we going to get reimbursed? Can we do this and do it sustainably? Are there any other kind of like research initiatives or any kind of data collection that you're doing that would kind of like potentially help strengthen the case for building the program or for even broader adoption, like across different organizations?
Yeah, I mean, we are a very data-driven organization. It's sort of in our bloodstream. And I'm constantly looking at outcomes, not just for this readmission program, but just for our limb loss program in general. We're collecting data in a lot of different categories. As we mentioned before, reimbursement rates, length of stay, their GG change score from admission to discharge, K-level changes. In the near future, we're hoping to synthesize all of this and really try to present this at some national conferences because our outcomes are in the 91st percentile nationally for the limb loss program. So that's in the context of that functional change score from admission to discharge. So I've been really happy with some of the outcomes that we're seeing so far, but of course we want to continue to grow this program and keep capturing as many different types of outcomes that we can so that we can grow it.
Oh, that sounds great. Yeah, it sounds like great outcomes that are coming out of that too. Look forward to hear more about that. My last question is kind of a fun one. I've kind of grilled you enough, I think, here. I think most of us in the field can kind of look back and we see stories of patients that have shaped our work, kind of energize us to continue to serve. Do you have an example of a patient that has gone through this program that has kind of done that for you?
It's hard to pick one.
I bet.
This program is something that brings so much joy to me at work. It's really fulfilling being able to, especially those cases where we've seen them that first admission and how challenging it is for them mentally, physically. They're not necessarily ready to be seen and ready to talk and work really hard to get to where they want to be. And so when you have someone that you can see that first day, and then see them come back in and see this total shift, where they're just now more themselves, their affect is brighter, they are just really just diving into this program because they can now see what's possible for themselves. We had someone who was a bilateral lower extremity diagnosis, and he was, it was a very long recovery process from those amputations. And so he unfortunately was fairly sedentary from the wheelchair level prior to coming in for this readmission program. But, I worked with him and his family to, we went through an appeals process to get him authorized to come in. So it was a lot of work on the front end, but once he was here and I watched, I always introduce myself because sometimes they don't remember me or sometimes they haven't even met me. So I always introduce myself when they admit, and I make an effort to really kind of cheer them on while they're with us. And this gentleman in particular, I just got to see how he came out of his shell and was laughing and smiling and pushing himself. And just the outcome that we got was so wonderful. And this perfectly led into our yearly walk, run, roll race that we do for this patient population. And he was able to participate in the race and walk it. And his wife was crying happy tears. He was grinning ear to ear. And that is something that I will never forget. It was just the best day to see this guy go like walking, having a great time. And that is the entire point of this program.
It's the reason you do it.
Exactly.
Meredith Mayton, Sheltering Arms Institute. Thanks for your time.
Thank you.